Welcome, everyone, to recap of day two of the IPVC conference. It's been an excellent conference so far. And my name is Troy Grennan. I'm an infectious diseases physician in Vancouver, Canada, also an HPV researcher. And I'd like to first start by acknowledging that I'm joining you from Vancouver, but it's really the ancestral unceded territory of the Coast Salish peoples, the Musqueam, the Squamish, and the Tsleil-Waututh nations. And I'd like to recognize all of the Indigenous lands from everyone joining us here today. I'm really excited to have two friends join along today. Dr. Pavón, who will be providing an update on the basic sciences sessions that occurred today, and as well as Dr. Bruni, who will be providing a public health update. I will be ending the session today with a clinical sciences update. So without further ado, I will hand it over to Dr. Bruni to give us a summary of what was interesting today in the public health world.
Well, many thanks, Troy. Good night, good day, good night here to everybody. I'm Laia Bruni, a medical epidemiologist from Barcelona, Spain. Today it's been a great day for the public health track. This is such an exciting time for public health and HPV prevention that we need many sessions to cover everything. And as many sessions are parallel, I had to pick only one. And my apologies in advance for the ones that had not been able to attend. I can't comment today, but I will watch them very carefully these coming days. Having to choose, I have prioritized the topics that I'm more involved in, and I recognize that I will give a totally biased recap. The problem is that I of only being available to attend one at the time. So we started today with the plenary with Drs. Gina Ogilvy, Peter Otes, and Tanya Cernusky. Well, I think it's been an outstanding session. First, we had Dr. Ogilvy discussing the case of cervical cancer from the point of view of inequity. No? Cervical cancer is the epitome of cancer inequality. It's the main cause of cancer and death in women from developing countries, but also in disadvantaged populations within high-income countries. Interestingly, Dr. Gilby discussed that many technological and digital innovations are being developed now to improve screening. But she posed the question, are these innovation being developed addressing health inequities in mind? Are these innovations addressing inequality or making them worse? No, we are already aware that, for example, our artificial intelligence algorithms, by using biased databases, may reinforce or worsen these biases, or the lack of racial diverse populations in the development or usability of studies. No? But the most important thing she made, I think, is she made us to question if our entire evidence base might not be biased. She advocated that the design of studies taking into account diversity, giving some fantastic examples on projects on sampling carried out in Uganda. She recommended also to read Dr. Figueroa works on how to improve studies designed to take into account all this diversity. So I think, her message was really important. After her went Dr. Tanya Cernusky. She has given very encouraging news regarding the global vaccine supply problem. She said that decreases in demand due to the COVID-19 and active demand management, coupled with supply increases over the past years, have led to significant reduction in the risk of global shortage. She said that a healthy supply situation will be likely reached in 2024. So this is in 3 years' time, more or less. No? And this is a result of existing suppliers expanding capacity and also pipeline candidates achieving licensure and WHO pre-qualification. Just now, we have a new vaccine a new bivalent vaccine produced in China, which has been pre-qualified by WHO, no? And also new products are expected in the short term. And in relation to this, in order for the world supply problem to be solved, she has commented on several points, but she has emphasized that it's necessary, an equitable sharing of available supply to serve low-income countries and low and middle-income countries as needed. So far, low and middle-income countries who need vaccines most, as has happened with the COVID vaccines, are the last to get them. And in the market dynamics, usually high-income countries are more prioritized. So this is very important. Okay. Next, we had Dr. Cotes, who opened our eyes about neglected tropical diseases, in particularly female genital cystosomiasis, affecting more than 40 million girls and women in Africa. Affects the cervix and the vagina, and it's associated with a lot of pain and bleeding and carries a high stigma and depression. They are trying to develop vaccines, but it's not easy without the help of the pharmaceutical industry. He has advocated joining forces with the HPV community to combat these diseases, as well. And that opened also a very interesting debate on how cystosomiasis eggs are carcinogenic and how this disease could be a factor in the progression of cervical pathology or influence the results of BIA or cervical cancer screening. So also this opens, the introduction of self-sampling for HPV also opens a new opportunity to develop combined tests for schistosomiasis to be developed. So that was a very, very enlightening plenary session. Well, and then afterwards, then we have different parallel oral sessions. We had one on cervical cancer elimination, another on prevention of oropharyngeal cancers, another on natural history. Later in the day, we had another 3 new parallel sessions on global impact, screening, and natural history. And well, maybe just I have this last one, I was in there because I was presenting also a communication, but I think it was very important because Beatrice Lovie presented what is going to be one of the reference books in the next few years, and on which many IPV members have been working, and that it's the IARC handbook on cervical cancer screening. This handbook has been developed by a working group of international experts, and they have performed structured evidence synthesis to evaluate the effectiveness of current screening methods. And now in the handbook, it's stated that HPV DNA test, it's more effective than either cytology or BIA in reducing cervical cancer incidence. In this regard, also Kate Sims from Australia presented modeling analysis on how to evaluate the impact of 7 different screening algorithms for 78 low-income and lower middle-income countries, just to support all these decisions and the 2021 cervical screening guidelines. And what her findings were that primary HPV testing approaches were the most effective and optimized benefits to harms and were cost effective compared to other approaches, okay? These findings support that the recommendation of using HPV DNA detection in a screen and treat approach or in a screen, triage, and treat approach, starting at the age of 30 years with regular screening every 5 or 10 years. And just in this same session, for example, Maxime Bonjour from IARC showed a novel way of presenting the impact of the HPV vaccine, performing a specific birth cohort analysis and estimating the expected and preventable cervical cancer for each birth cohort. It's a different approach from what we are used to. And I invite you to look at the paper that it's already published, it was published this summer, that shows a very different picture, a very different map on on cervical cancer incidence than the one we are very used from Globocan. Maybe I don't know if I give the floor to my colleagues here.
Yeah, thank you, Dr. Bruni. Sorry, yeah, go ahead. Maybe we'll go ahead. I just want to mention that you've given us a lot of things to go back and look at. And I also want to mention, I unfortunately missed the plenary session this morning with Dr. Gina Ogilvie and the others, and Dr. Hodes. So I'm very happy you presented on it. I was very excited to hear about it. I did catch the very last part, and there was some really good insight from that session, because one of the questions Dr. Ogilvie received was around collecting race-based data. And her point was, she provided some resources about how to do that. But her point was really about not if we should do that, but how we should do that, yes, which I thought was a really good way to cement that up. So I just wanted to add that in there because I had a little pearl that I remembered from that session. So with that, thank you very much, Dr. Bruni. And we'll move along to Dr. Pavón, who will present on basic sciences.
Thank you. I'm Miquel Pavón from the Infection and Cancer Laboratory at the Catalan Institute of Oncology, mainly focused on HPV research and basic science. I have to say that today was a really good conference day with plenty of good talks. I really enjoyed the plenary session 4. The talk of Jennifer Grandes is a masterful example of how using in vitro models, PDX models, and also tumor tissue obtained from patients, how you could just identify mutations in the P3 kinase pathways that are at the end crucial for the HPV-associated head and neck tumors. Mutations that at the end are also targets for new drugs and drugs that in the near future, I'm sure that could be useful to develop more specific treatments for these patients that suffer head and neck cancers associated with the human papillomavirus infections. Also in plenary session 4, I take the opportunity to attend to the talk of Vincent Bonamura, and this helped me to learn or to know more about the respiratory papillomatosis. This is a disease that we still know little about it, that is associated with the low risk types, with a low incidence, and I found really interesting how the author showed that the main factor associated with the recurrence of this disease is the failure of the immune system. Regarding the basic science oral sessions, today we had 2 sessions, one of them focused on carcinogenesis and the other one focused on antivirals. If I tell you the truth, due to the difference in the time zone between Toronto and Barcelona, I was not able to attend to the carcinogenesis sessions. I focused my attention on this last session that was focused on antivirals. And in this session, you could find different approaches in order to develop compounds that could be useful to just kill HPV positive cells, or just to inhibit the carcinogenesis in epithelia that have been infected by this virus. No? The first talk of Sheila Graham showed us her advances using splicing inhibitor of the serinarginine protein kinase that is able to inhibit the viral replication, inhibiting E2, L1, and E4 proteins. Then Sebastian Bendel, using preclinical models, showed us how a specific inhibitor of the PCNA could be selectively used to kill cervical cancer cells. Michelle Osborne, with a nice talk, show us which could be the effect of the MEK inhibitors in using mouse models of the papillomavirus infections. And finally, we had a great talk of Richard Kohler, who developed machine learning models to evaluate the treatment effect on organotypic raft cultures. I would like to finish my recap just recommending everyone to take time to also follow the short oral sessions where you will find very good talks from a wide range of topics, many of them presented by young researchers. Again, congratulations to the organizations and all the authors. And I now just give the floor to my colleague, Troy. Thank you.
Thank you very much. And I guess I'll end our recap day today with my thoughts on some of the clinical sessions. I will mention as well, as some of my colleagues here have mentioned, that it's impossible to do justice to everything we saw today in such a limited time. And thankfully, I did have to pay attention to really close attention to these sessions today because they really didn't fall within my usual area of expertise. So, but nonetheless, they were very interesting. So for the clinical sessions, there were 2 clinical sessions today. The first one in the morning was more on biomarkers and diagnostics, and there was another little, which I'll talk about in a second, another session or another presentation that didn't quite fall into those, but it was a case series, which I'll talk about. So in this first session, there was an interesting talk by Dr. Monica Milano, who presented on DNA methylation. And so for those of us who are somewhat familiar with DNA methylation in HPV, there's been a lot of work on it in the past and ongoing, but with a lot of mixed results. So this was a study that was done in Papua New Guinea. And the aim of the study really was to check methylation levels. And 3 different methylation markers were used, host methylation markers were used to predict HSIL in women who had high-risk HPV, who were high-risk HPV positive. And the other part that was, the other aim that was sort of a sub-aim of the study as well was to compare these markers when collected by self, so self-collected, and those were vaginal samples, versus clinician collected, which were endocervical. So slightly different anatomic areas of collection. And overall, a lot of data was presented in these very short presentations. A lot of data was presented, but overall, generally the pattern was that the levels of methylation generally increased with the grade. And there were some key differences between self and clinician collected samples. Overall, the sensitivity and specificity for the clinician collected samples were around 81 and 70. So sensitivity 81, specificity 70. And that's overall for the 3 different markers. And then for the self-collected, it was about 68 sensitivity and 52 specificity for the self-collected group. And as the specific methylation markers, the one that sort of stood out most was a microRNA marker. So that was one really interesting, I thought a really interesting talk from this morning in that session. The other talk, there was another talk in that session that I thought was really, really fascinating. It was presented by a medical student from Miami, Austin Wyant, and he presented a case series on using combined systemic as well as intralesional 9-valent HPV vaccination in the treatment of squamous cell carcinoma of leg lesions. And it was a case series. So the background here is kind of interesting because as many clinicians might know and others might know, with squamous cell carcinoma of the skin, the usual treatment is surgery. So Mohs surgery is quite common, and often radiation will be done as well. But in some people, depending on age or comorbidity, sometimes those aren't really options for people. So coming up with an alternative approach to these might be a good thing to do. And so this was a case series of 4 cases. The patients ranged in age from their 70s, I think 76 to 90, and they were all leg lesions, squamous cell carcinoma leg lesions. And in all of without getting into the details of all the specific clinical stuff, all patients had either had surgery and radiation, or maybe they didn't, but they all had a 3-dose series of the vaccine intramuscularly, and then various combinations of intratumoral, I guess, intralesional HPV vaccine as well, and all of them resulted in clinical resolution. So I didn't see long-term follow-up data at all, but at least at the time of follow-up, which I think roughly was about 1 year for each of the patients, the lesions were gone. So it's interesting. A question came up during the question and answer period asking, maybe it has nothing to do with HPV at all. The general thought is that prophylactic vaccines aren't really useful for these kind of things in the cervix or in head and neck. So what's the deal here? Is it just an immune reaction from the vaccine? And a very good question came up about whether these individuals had received other vaccines as well, and maybe something there. So anyhow, for an N of 4, not something we can hang our hat on, but really, really interesting nonetheless. The other session in the afternoon, the clinical session in the afternoon, was on vaccines, and there were a couple of things here as well that I thought were interesting. So there was so it wasn't really presenting the results of a study, but it was presenting the kind of design of a study that is being that I think started enrolling in March of 2021, and it's a study from Merck, and they're looking at a phase 3 study on immunogenicity and safety of a 2-dose 9-valent HPV vaccine with an extended dosing interval. So I think the result of this, not available yet, but I think the result of this potential would be very interesting. They have it's not complicated, but it's quite involved in terms of the kind of the study design. They showed the study design on the slides, and there's sort of 6 different cohorts. So Cohort Zero, which is what they're calling, is, they're recruiting these individuals from a health maintenance organization in one country. They're 10 to 15-year-olds who've received 1 dose greater than 1 year or greater pre-enrollment, and they'll be revaccinating these individuals and looking at how those individuals respond to this extended dose. And the hope with this is Cohort Zero, is that it'll provide some sort of a pre-show for what might happen in the other cohorts. And then the other 4 cohorts, the other 5 cohorts are the extended dosing interval, and then Cohort 5 is the standard dosing interval. So they're going to do a variety of things. So they're going to do, dose 1 on day 1 and then month 12, dose 1 on day 1 and then month 24, month 36, and then month 60. So out to 50 out to 5 years. Because there is a little bit of data in the background that has shown that might be useful. So their primary immunogenicity endpoint is the GMT titer at 1 month post last dose. So that'll be really interesting, I think, to see. The last session that I'll just quickly mention is by Dr. Jura. It was during the same session, and he analyzed 3 phase 3 trials. So it was a retrospective study looking back at 3 different trials, so Future 1 and Future 2, as well as another study, V503-001. And basically, the aim of the study was really to look at the effect of the 9-valent HPV vaccine on the risk of developing HPV-related cervical or genital lesions after surgery, so like a LEEP or a conization. And essentially, what was seen was that when the 9-valent HPV vaccine was given pre-surgically, there was a significant decrease in the HPV incidence in the cervix, the vulva, or the vagina, and that was followed up at about at least 6 months. At about 6 months of follow-up. And so again, he did get a good question about that, about sort of how can we translate this clinically? Like, what's the benefit of this? Because we can't go back and vaccinate people once they've had these procedures. And I didn't know this, but apparently there are some randomized trials out there for women undergoing these types of surgeries with vaccination. So those will be very interesting to see. So so today for my sessions, in summary, some presented data, and then the promise of some really cool data coming forward. So all in all, for me, it was a really great day as well. I'd just like to thank my colleagues here who are joining us from Barcelona, where it's very late. It's 2 o'clock in the morning now. So thanks for sticking it out with us. And to everyone out there, please join us for tomorrow, for our sessions tomorrow. Thank you very much and have a good night.
Thank
Thank
you.
you. Enjoy the
Bye-bye.
conference. Bye.